Namaskar. You are watching Dr. KK Med Talks Fridays with Dr. Anita Kant, non-stop show 858th episode. Let's have the headlines of the day. As per the results of a large-scale survey conducted across India in 2020, about 16% of women respondents between the ages of 20 and 29 years suffered from PCOS. The prevalence of PCOS in India is mainly attributed to poor lifestyle, unhealthy eating habits, and lack of physical activity, say doctors. According to a new study published in the Journal of Clinical Endocrinology and Metabolism, environment could be playing a critical role in the expression of PCOS. A recent study examining the relationship between psychiatric and reproductive system disorder in the women revealed a high rate of co-occurrence between the two, with specific association between polycystic ovary syndrome and depression or anxiety. Researchers confirmed that having a history of polycystic ovarian syndrome multifolds the risk of developing pancreatic cancer. So let's go to the topic of the day. We will be talking about management of PCOD, and to tell us more about PCOS and PCOD is Dr. C. Sharath Kumar. Welcome, Dr. Sharath. Welcome,
Thank
sir.
you very much, madam. Good evening to all the doctors. This evening topics is quite interesting as well as very relevant.
Today, we will be talking to our viewers on Facebook and YouTube, which will be general public and including doctors also. So, Dr. C. Sharath Kumar, the esteemed principal professor and head of Department of Reproductive Medicine and Surgery at Mediwave Institute of Medical Sciences, Mysore, is highly acclaimed with a remarkable track record of success in field of education. A man of great distinction and knowledge, he has steered the institute to new heights of success and has been a mentor to countless students over the years. His commitment to excellence, his dedication to the cause of education, and his unwavering passion for learning have helped him lead the way and make a lasting impact on the institute and also on the students. He is a beacon of hope and an example of success for every aspiring student, including me. Now we will be talking about PCOS today. Shall
Hello.
we, sir? Shall we, sir, start? Can you hear me, sir? Hello? Hello? Can you hear me, sir? Dr. Sharath? Dr. Sharath, can you hear me? I think there is some internet problem. It will be sorted in a minute. So today we will be talking about polycystic ovarian disorder or polycystic ovary syndrome. These PCOS or PCOD, these are very, very common in the women of reproductive age group. Um, Actually, टीनेज में ये नॉर्मल होता है टू सम एक्सटेंट एंड ऑल्सो पेरीमिनोपॉजल एज ग्रुप में कुछ हद तक नॉर्मल होता है और दोनों चीजें सेम है, इसलिए मैंने दोनों के नाम लिए ताकि आपको पता रहे कि दोनों एक ही हैं, चाहे हम उसे पीसीओडी नाम से पुकारें चाहे पीसीओएस नाम से पुकारें. सो व्हाट आर द कॉमन सिम्टम्स एसोसिएटेड विद इट. जब तक डॉक्टर साहब लाइन पे आते हैं मैं आपको थोड़ा बहुत बता देती हूँ. कॉमन सिम्टम्स यही होते हैं कि सबसे पहली चीज होती है पीरियड्स इरेगुलर होते हैं. क्यों इरेगुलर होते हैं? क्योंकि ओवरीज में इतनी सारी छोटी छोटी नन्ही नन्ही सिस्ट बनी होती हैं, उनमें से कोई भी मेच्योर नहीं होती, इसलिए एग बनना, मेच्योर एग बनना पॉसिबल नहीं हो पाता हार्मोनल एनवायरनमेंट की वजह से. और जब तक एक एग मेच्योर नहीं होगा उन सब में से, वो फटेगा नहीं, तब तक पीरियड्स रेगुलर नहीं होंगे. तो एब्सेंस ऑफ ओवुलेशन या एनओवुलेशन जिसे बोलते हैं, वो एक मेन कॉज, मेन फैक्टर गिना जाता है पीसीओडी डायग्नोज करने के लिए, और उसकी वजह से पीरियड्स इरेगुलर होते हैं। सेकेंड थिंग, क्योंकि पीरियड्स इरेगुलर होते हैं, हार्मोन्स चेंज हो जाते हैं, थोड़ा सा वेट अगर ज्यादा हो या इसकी वजह से वेट बढ़ जाए तो वो हार्मोन्स जाके फैट में बैठते हैं, और नेचुरली द फीमेल हार्मोन्स टर्न टू मेल हार्मोन्स, और एक्ने और हर्सुटिज्म हो जाते हैं। So, doctor, how is PCOD diagnosed and what tests are typically used to diagnose this condition?
Thank you very much, madam, for such an excellent introduction. So I am very grateful to you for using so many adjectives. So, madam, there is a lot of confusion between PCOD and PCOS in not only in the general public, in the patients, as well as in some of the doctors, of course, exception to the consultants. So, just I would like to give little clarification because many of my patients come with a scanning diagnosis as PCOD, and they will be very very unhappy and apprehension. Oh, that will happen, this will happen. I was told that cancer of the cervical region will occur, like that, like this they will come. So PCOD is slightly different from PCOS, though both are used synonymously in most of the literature, layman literature. PCOD, that is polycystic ovarian disease, is a disease which is diagnosed by a sonologist. As soon as he or she sees the ovaries through transvaginal ultrasound, she sees multiple pearl-like cysts all around the ovary, at least 6 to 8 millimeter in size, minimum about 10 to 12 in each ovary. That is polycystic ovarian disease. Any lady who has got PCOD, she need not suffer from PCOS. Polycystic ovarian syndrome is a multiple signs and symptoms all put together and called as a syndrome. Syndrome is different, the disease is different. So all the ladies who get the diagnosis of PCOD need not worry because they may not fall into the PCOS. So PCOD is found in about 25% of the general population, that is ladies, whenever we see the scanning. And many of them may be having children also. They may not be infertile. And many of these ladies who come with the diagnosis of PCOD may be even fertile also. So there is slight difference between PCOD and PCOS. PCOD is a diagnosis given by a sonologist through ultrasound scanning, looking at the ovaries, diagnosing that she has got multiple cysts. PCOD is generally a little genetic in origin, and the main work, the main thing behind the PCOD is some of the cysts, which that is follicles, which have to be released every month, they may not get released. They may not get mature. At the time of reaching about 7 or 8 millimeter, they stop growing. In that cycle, they don't mature and they don't ovulate, and they remain in the ovary as a small cyst, that's a small follicle, pearl-like follicle. That is just a disorder of the lady, and some of the months she may release also. Some months she may not release. The cycle will be usually irregular. The cycle may be 2 months, 3 months. In 3 months, what happens? Two cysts remain. But third month, she ovulates and she may even become pregnant also if she's a married lady and wanting to become pregnant. So PCOD is a disease diagnosed by this one. And PCOS is slightly different. It is an advanced stage of PCOD. That is a PCOD leading with metabolic disorder, and she gets so many other signs and symptoms like obesity, hirsutism, baldness, that is of the male characteristic, thinning out of the skin, thinning out of the hairs, and androgen like symptoms, and irregular cycles, infertility. Ultimately, she lands up infertility. So, most of the times, PCOS and infertility, obesity go hand in hand. Whereas a girl who is diagnosed with PCOD, she may be thin, she may not be obese at all, but she comes with a at that time, it is the duty of the consultant to differentiate the two, say that PCOD is okay. It may be slightly genetic in origin. You need not worry unless she has got other signs and symptoms of syndrome. So today we will restrict ourselves to the PCOS rather than PCOD. Many times PCOD need not be treated unless she comes with signs and symptoms of PCOS. So the first and foremost thing in the diagnosis of PCOS is the the general examination. General examination, look at the lady whether she is obese. Take her body mass index and ask her lifestyle and ask whether she is a smoker or alcohol. Of course, in India, it may not be that the ladies don't drink and smoke too much. However, history has to be taken and ask whether she gained the weight recently or is it hereditary from the beginning itself. So, general examination to exclude and hypertension and other things have to be ruled out in the general examination. Then coming to the other investigations, first and foremost investigation to be done is the general routine blood test to rule out diabetes and hormonal examination to rule out hyperandrogenism. So hormones to rule out hyperandrogenism and the general examination to rule out the hypertension. Then comes the particular examination, that is the ultrasound scanning. See, general abdominal ultrasound through the bladder may not give full view of the ovaries. Most of the times, I have seen as a sonologist also, many times the diagnosing radiologist, if he is a male, he usually hesitates for the transvaginal examination and does only parabdominal examination and declares that the ovaries are normal. But when you go through the vagina and go near the ovaries through transvaginal ultrasound scanning of high resolution of the nature of 7.5 megahertz, then you will look at the ovaries, oh, enlarged and multiple follicles and unruptured follicles. So, diagnosis, the key gold standard diagnosis for PCOS is the transvaginal ultrasound scanning and hormonal examination. These two clubbed together. If there is hyperandrogenism, obesity, and added on with polycystic ovarian disease through TVS, if two of these three are there, according to Rotterdam standard of European Society of Gynecology, then we can safely declare that she has got PCOS. So this is the gold standard for the diagnosis of PCOS, madam.
So
Yes, madam, we can continue.
can
Yeah,
PCOS affect a woman's fertility, and if so, how?
madam, the most of the times ladies come for infertility. Then we check up and find out that she has got obesity, then hair distribution of little thinning out, and also hirsutism, unwanted hair at unwanted places, especially on the face, on the back of the neck, then acanthosis nigrica, and acne. And looking into the diagnosis, polycystic ovarian disease, then we come to a conclusion that she has got the PCOS. So, and about 50% of the ladies with PCOS land up in the infertility. So, why they become infertile is because of the amenorrhea or oligomenorrhea, severe oligomenorrhea. They don't menstruate every month because the ovulation is not there, the eggs are not released. When there is no egg release, the ovulation will not occur and it will be added as a cyst in the ovary. And once there is no ovulation, she will not fertilize. So, irregular cycle, amenorrhea, and the androgen, that is hyperandrogenism, adds for the infertility. Added on to that one, obesity. Obesity itself is one of the cause for infertility. So all the four things, obesity, androgen, hyperandrogenism, and ovulation, and no menstrual cycle, these are the key factors for lady being landing up in the infertility.
So, how is
Yes.
PCOD treated and
Yeah.
PCOS treated, and what are the different options available to the patients?
Madam, this is an excellent question, most commonly asked. The most important aspect of the PCOS management is lifestyle management, lifestyle modification. And most of them, that is 90% of these ladies, PCOS ladies, will be obese. So, the obesity is one of the main cause for hyperandrogenism. And the testosterone level will rise and there will be no ovulation and ovulation, and FSH and LH will come down, estrogen will come down because testosterone is more. So lifestyle modification includes the weight loss. Weight loss is best done by diet and exercise. Absolutely, there is no replacement for diet and exercise for weight loss. So seriously, we have to tell her, if you want to become pregnant, lose weight. Even if she loses 5% of her body mass index, the ovulation will start and she will get back her periods. So seriously, if you tell her that these are linked, these are hand and glove, then only she will understand. If you simply tell diet and exercise, do you know what she will tell? So many ladies who are bigger than me, who are larger than me, who weigh more, they have become pregnant. Why I have not become pregnant? So they refuse to accept the link between the obesity and the infertility. See, this has to be made very clear. And if she cannot lose the weight with the diet and exercise only, then we have to add insulin resistors, the metformin, or even statins, atorvastatin for losing the weight, or even other medicines to reduce her appetite, and to see that the unwanted fat is not absorbed in the GI tract. So many medicines are available for the GI tract to prevent her gaining the weight, and also to see that whatever she unwanted thing she eats, the junk food, it goes through the stools unabsorbed. So the second line of management of the weight is through medicines. If the lifestyle modification, that is diet, exercise, yoga, if it doesn't help, then the last one is bariatric surgery, where we may have to interfere and take out the fat itself, or even to go and cut some of the parts of the GI tract to reduce the absorption itself. That should be kept as a last resort, not in the first line of defense. So that is the lifestyle modifications. The second line of drugs is, it depends upon whether she wants to become pregnant or she doesn't want to become pregnant. If a PCOS lady has come to not to become a pregnant, if she is only for the treatment of PCOS, then the best thing is oral contraceptive pills. Even cheap oral contraceptive pills, they work wonderfully. You need not go for very high cost OCPs. Even the government supply, they work easily. So if the lady is economically poor, the best thing is to ask her to buy Mala D or Mala N, and every month they say, if she takes, cycles become regular, PCOS is also controlled. Added to that, diet and exercise, they work excellently. So oral contraceptive pills or gel or paste or even injections, monthly injections or 3 months depot injections, or even implants, or even the coated copper teas, that is the Merina, intrauterine contraceptive pill, the contraceptive devices coated with these estrogens and progestins, they will work wonderfully. So if she doesn't want to become pregnant with OCP or gel or paste or patches or IUCDs coated with these things, will work excellently. But if she wants to become pregnant, then the treatment is entirely different. We have to go for clomiphene citrate or letrozole aromatase inhibitors. That is, they will work excellently by ovulation induction. Clomiphene citrate, it is an anti-estrogen and it works at the hypothalamus level and blocks the estrogen receptors, and it will make the pituitary to release more FSH and LH. So ovulation induction is done through that cycle. That is clomiphene citrate. If it is given from second day to fifth day, they work nicely. The last drug, that is letrozole, can be given if clomiphene citrate fails. If these two fail, then you have to go for gonadotropins, that is FSH injections we can go, and also LH injections we can start if these fail. Otherwise, the first order of defense shall be oral contraceptive pills. And ovulation induction has to be done, and if the husband's sperm is good, go for natural intercourse, give them the date. If the husband sperms are not good, concentrate it and do IUI, intrauterine insemination, on the day of ovulation. Before the day of ovulation, give an HCG injection, 10,000 units. 36 after giving the HCG injection, ask them to have a regular unprotected intercourse, or go for IUI if the husband's pumps or parameters are low. And the 3 to 5 cycles of IUI fail, then the last resort shall be the IVF. Go do the down regulation, use Lepride depot or some depot, and down regulate the hypothalamus, take the pituitary into your control, give FSH injections, do hyperstimulation of the follicles, and retrieve the follicles and retrieve the ova, and add with the sperm of the husband, and do the ICSI, intracytoplasmic injection, and create an embryo and give back the embryo to the uterus. That is IVF cycle if everything fails. That is the last this one. And between these, we can try the laparoscopic surgery, ovarian drilling, drill the ovary, or even if the ovaries are very big, do wedge resection of the ovaries and reduce the production
Nice.
of the androgen, and stimulate the ovaries, and you will be quite successful with the surgical intervention. Madam, over to you.
Mm. So, can PCOD be cured or is it a lifelong condition? A viewer wants to know.
Yeah, they most of the times PCOD, as I told earlier, it is quite genetic in origin, but most of the times they may be fertile also. And even if they are not fertile, with very minimal intervention, that is with 5 clomiphene citrate, they will become pregnant. PCOS is a morbid condition. It's a metabolic disorder. Again, it may be of a genetic in origin, and because it's a metabolic disorder, it may be a lifetime disorder. We may control it. We cannot totally remove it. Even after surgical resection, also 100% it is not relieved. After 5 years, she may come back with the same signs and symptoms. So, since it is a metabolic disorder, it is almost a lifetime disorder. It has to be managed throughout her reproductive life till she comes to the stage of menopause. After that, it is left to her to take the treatment or not to take the treatment.
And what kind of follow-up care is necessary for patients with PCOS?
This is a really excellent question, madam, because there are so many comorbid conditions associated with the PCOS. In the introductory remark itself, you told about the relationship of PCOS with other metabolic disorders like cardiac disorder, lipid disorders, and even renal disorders, and even other general metabolic disorder like hypothyroidism, and others. Because this is hormone related, the PCOS, so many other hormones are also affected, including the thyroid hormone. So the management of the PCOS is not only from the fertility point, it is also from the general health point also. Because she has got so much hirsutism, so much obesity, they have to be managed. Hirsutism has to be managed with the anti-androgens like spironolactone or aldactone, or you may have to go for hair removal techniques, or even you may have to refer her to a dermatologist for epilation by laser surgery, or by other electrolysis lysis of the hairs, unwanted hairs, because the look is very, very important. So hirsutism has to be taken very seriously, because she may not be able to mix up in the society with so much hairs on the unwanted places like the chin and other places. And acne, there's another deadly disease. Patients will be worried about the acne. It has to be treated and with creams or other thing. And also, acne can be treated with anti-androgens, and even the oral contraceptive pills. They will also help in a large extent to control the acne. Lifestyle modifications, the reduction of the weight, and anti-androgens will definitely help, along with the local applicants of creams. They will help the this one. And acanthica nigrica, that can also be treated like that. And other comorbidities, that is hypertension, diabetes, type 2 diabetes, because she is already obese. Type 2 diabetes, another deadly complication of PCOS. It may cause heart failure, heart attack, and even high blood pressure.
So I think we are having again some internet issues. In the meanwhile, I would like to answer a question एक viewer ने पूछा है कि how important is regular follow-up care for managing PCOS and what should patients expect during these appointments? रेगुलर फॉलोअप इसलिए चाहिए होता है कि डॉक्टर देखेगा आप अपनी लाइफस्टाइल चेंजेस कंटिन्यू कर रहे हो कि नहीं, अपनी डाइट ठीक लेके वेट कंट्रोल किया है या वेट लॉस हुआ है कि नहीं। कभी भी कोई भी डॉक्टर आपसे ये नहीं कहेगा जाइए और तुरंत में 10 किलो कम करके आइए। इवन अ स्मॉल वेट लॉस लाइक हाफ केजी पर वीक पर मंथ इज अप्रिशिएटेड। जैसे डॉक्टर साहब ने बताया था कि 5% भी अगर आपका फॉल होता है पूरे वेट में से, आप सपोजिंग 90 केजीज 95 केजीज के हैं, तो आपका धीरे धीरे जो जो वेट लॉस होगा वो आपके अमाउंट ऑफ मेडिकेशन को कम करेगा और आपके अंदर से बीमारी को कम करेगा। एक क्वेश्चन और सुनने वालों ने पूछा है कि क्या कोई सप्लीमेंट्स या ऑल्टरनेटिव थेरेपीज हैं दैट कैन हेल्प मैनेज पीसीओडी सिम्टम्स एंड आर दे सेफ टू यूज? कुछ चीजें लाइक विटामिन डी डेफिशिएंसी पीसीओएस के साथ जोड़ दी गई हैं। और यस सर, सो एक
Yeah,
क्वेश्चन था, देयर वाज अ क्वेश्चन, आर देयर एनी सप्लीमेंट्स और ऑल्टरनेटिव
yeah.
थेरेपीज दैट कैन हेल्प मैनेज पीसीओएस symptoms and how safe they are there to use?
Yeah. Yes, yes, very good question, madam. Just now I heard that you were talking about vitamin D. It's a very, very important
Mhm.
constituent. It's an adjunct for PCOD. So many other adjuncts have been told that they help in PCOS, though they are not 100% successful. They are quite successful up to 50 to 60%. And a success of 60% is excellent when we treat an infertility lady. So, inositol and this melatonin and vitamin D3 and even L-argine, L-carnitine, citrulline. These have been told that they do act as adjuvants in the treatment and management of PCOS. Definitely, we have to give them because the lady will also be happy because we have given so many medicines. Because if you just give five clomiphene citrate and send her back, she thinks that, oh, he is a super specialist, he has given only five tablets. So the psychological factors work an important role. So when we give such adjuncts, they will be happy, and the psychological factors work. They may be even working as placebos, but they do work. And so many studies have shown that myoinositol, then L-carnitine, citrulline, they have found to work excellently in this one. Of course, there are equal number of papers against them also. But as practitioners, we have to go for positive attitude, not for negative attitude. Nothing wrong in adding, and absolutely there are no major side effects in adding vitamin D or inositol or metformin and other medicines, including coenzyme Q10. Definitely they do work. In my practice, I am happy with them. In fact, combinations also come. For example, Ovacare Fort, it contains all these things. So such combinations we can take and give them. Patient will also be happy. And success, if it comes, let us all share the success, including the pharmaceutical companies. Nothing wrong. And if they cannot afford, then we can restrict ourselves to only basic medicines, that is clomiphene citrate or letrozole and metformin. Basic drugs are these three only. Adjuncts, it is left to the clinician as well as to the patient.
Okay. So, how can, we were talking about
Yeah,
psychological aspects. How can patients cope with the emotional and psychological
yeah,
challenges associated because of maybe infertility or,
yeah,
body image concerns?
yeah. Madam, both are deadly the enemies of the lady because one thing is she's worried about the body, especially acne, the hirsutism, and abdominal fat. All the three make the lady so ugly looking that she will not go to the parties at all. She cannot dance with others because of her abdominal obesity. She cannot show her face because of the hirsutism and also because of the acne. So it has to be taken seriously and treat acne hirsutism as seriously as PCOS. Use the medicines liberally to see that her all these problems come down so that socially she mixes with the society. Once she mixes with the society, psychological factors plays a tremendous role. She will come out of her depression and she definitely the PCOS will be combated. So treating them with all these things is to see that she comes out of the depression because of the body image. And second point, what you told is about the other aspects. So
सो आई थिंक फिर से कुछ इंटरनेट प्रॉब्लम हो रही है। सो इस इन सब प्रॉब्लम से जूझने के लिए देर आर सर्टन रिसोर्सेज लाइक ऑनलाइन ग्रुप्स हैं, सपोर्ट ग्रुप्स हैं और ऑनलाइन कम्युनिटीज हैं जो कि पीसीओएस के अपने एक्सपीरियंसेस शेयर करते हैं और बाकी सुनने वालों को वो काफी ज्यादा सपोर्ट देते हैं कि दिस इज नॉट द एंड ऑफ द वर्ल्ड, कि आप सोचें कि ये हो गया तो अब मैं कभी ठीक नहीं होंगी या ये हो गया तो मैं बाहर कैसे जाऊं। हर चीज के लिए एक तरीका होता है and you have to learn to live with yourself and move on in life. So I would like to thank Dr. Sharath, हालांकि वो हमारे साथ कनेक्ट नहीं कर पा रहे हैं, for joining us today. Could you show us the certificate please in the meanwhile? So we will share this certificate with Dr. Sharath. कुछ इंटरनेट प्रॉब्लम्स की वजह से मैसूर से वो हमारे साथ कनेक्ट नहीं हो पा रहे हैं. That will be all for today. Dr. KK Med Talks will return tomorrow at 7 p.m. with another edition of the show. हम डॉक्टर शरद से फिर मिलेंगे. उनकी स्पेशलिटी सेक्सुअल प्रॉब्लम्स है और इनफर्टिलिटी के अलावा, तो हम डेफिनेटली इसके बारे में उनसे फिर से एक मीटिंग करेंगे आप लोग के साथ. कीप वॉचिंग डॉक्टर के मेड टॉक्स. नमस्कार.